Hello, and welcome to session 3, Successful Clinical Trial Enrollment with True Advocacy Collaboration During Challenging Times. My name is Shazia Ahmed. I'm Senior Director, Head of Patient and Physician Services at UBC. Today, I have the honor of moderating this session. This is a topic I'm especially excited about, as I've had the luxury of being a bridge between industry and advocacy with a special concentration in rare diseases for quite some time. I'm so pleased to have Dr. Sanjay Shukla, President and CEO at aTyr Pharma, Trisha Shivas, Chief Strategy Officer at the Foundation for Sarcoidosis Research, FSR, and Erica Courtenay-Mann, member of the FSR Women of Color Patient Advisory Committee. Before we get started with the discussion, I'd like to touch on some reminders on where we are in the rare disease landscape that really touch on the tone on why it's so important for advocacy and industry to work together. Rare disease clinical trials are hard to start and enroll. Relationships with advocacy organizations can make or break whether a clinical trial is successful. We need to really understand where the patients are in order to successfully run clinical trials in the rare disease space. We need to think critically in trial implementation to allow for diverse participation. We all know there are 7,000 plus rare diseases, and patients experience significant diagnosis delay. There are only a few hundred FDA-approved treatments, and even those that have treatments, there are limitations on impact a particular treatment has across individuals. Most rare diseases are not well understood and tend to be serious, complex, and lifelong. Industry and patient advocacy collaborations are key to success for all phases across drug development. Today, we'll be discussing lessons learned from a phase 1/2 trial for pulmonary sarcoidosis, despite being faced with a challenging pandemic environment, and advice for clinical trial successes in the future. Dr. Shukla, I'd like to start with you. What barriers did you see in the research community specific to pulmonary sarcoidosis?
Certainly there were challenges, and thank you for inviting me on this panel, Shazia. I think one of the first things that we encountered when we started to think about moving our potential therapy into sarcoidosis was really understanding the disease. Disease education, and it starts with mechanistic understanding, the mechanism of action, the etiology. And we took a rather unorthodox approach because we work in a very new area of biology that it itself is not in any of the medical or immunology textbooks. So I reached out to a number of patient foundations very, very early on when we had preclinical data in animals. So that was a little bit unorthodox. We started to learn a lot more about sarcoidosis, about the mechanism, the potential, perturbations in the disease where we could actually make an impact. And we really sat with experts to understand the disease, really early on. So the first part was really that kind of understanding of the disease, the pathophysiology. Then we started to really understand the burden of disease. and where a new therapy might make a potential impact. With our therapy seeing early signals as a potential anti-inflammatory or anti-fibrotic, we thought it was a potential good disease for us to target. But that involved a lot of discussions and frankly, a lot of teaching on the behalf of patients and experts, where they taught us, look, here's what the disease is about. Here's where there's a burden of disease. And here's where we need a better therapy. So as we started to generate more data, we really opened the doors to show experts and groups like the FSR what our preclinical data looked like, and took a very sort of different approach, saying, do you think this would be a useful therapy to move into sarcoidosis? As we started to generate more data, we started to understand a little bit more about, for example, the treatment burden, current treatments. And that's where we started to really start to think about how do we design a trial, but a trial that also focuses rather early on making an impact for patients. So what could we actually do with a protocol that would have a meaningful signal? A lot of biotech companies, and I've been in the industry for quite some time now, may focus on, for example, a biomarker, which can be wildly important from a scientific point of view, but does that make an impact in the patient's lives? So there's a lot of risk involved in taking some of the approaches we took with our early protocol, which focused on potentially looking at a steroid-sparing design, because we learned from patients early on that steroids are just awful. And if we are going to create a new therapy, let's do so by immediately starting to answer questions. Could this be useful in peeling back some of the steroid utilization, or even potentially being something that could replace steroids? So all of these things involved the first challenge of sort of being brave enough and having the ability to reach out to groups. And it wasn't just the sarcoidosis community, but we reached out to other patient foundations in pulmonary fibrosis, scleroderma, where we also thought our therapy might be useful. But in total, it involved an approach where we really sat side by side to really understand, what we don't know from a mechanism point of view. What do we know about the disease? What don't we know about, treatment? And I think it was a full journey here that I'm really grateful to have partnered, really, really early on with the FSR.
Great, thank you. That's very helpful. Erica, a question for you. As a patient, why is it important that pharmaceutical companies listen to patients when creating trials?
Thank you for that question. Patients navigate life with their disease, and they have a daily journal of nuances and life hacks to help them survive. Listening to patients can help pharmaceutical companies, bring in what matters most and patient priorities to the forefront. It's really imperative that the pharmaceutical companies, they integrate what really matters to the patient the most and how they affect their quality of life. They need to put that type of mindfulness into their clinical trials. To understand what matters most to patients, let's take, for instance, or let's look at one of the biggest quality of life measures is how a patient does on steroids. How a patient body processes steroids, that is often the key. That kind of sets the tone of their quality of life measures. Steroids are often the first line of defense for treating sarcoidosis. So you can't avoid them, you can't get around them. They effectively reduce systemic inflammation. However, in tandem, they also cause some patients immediate weight gain, depression, shame from their changing appearance, and also mood swings, just to name a few of the side effects. So a patient that is experiencing any of these side effects is really going to be looking for a medical solution that can severely improve their everyday quality of life. A medical solution that can reduce the inflammation, but not cause a disruption to their everyday life due to side effects. That's what patients are looking for. The working mom is going to want a solution without having to manage depression while parenting her children. And outcomes vary per patient, so it's really in the pharma company's best interest to listen to a wide sample of patients. Patients offer valuable insight and a plethora of empirical data through their varied experience that can truly serve as a bridge between the patient's needs and the medical solution that lead to positive health outcomes. When they first started treating my sarcoidosis, I was on prednisone. I blinked and I gained 15 pounds. I also suffered from increased depression along with a classic moon face. And one day at work, I happened to catch a glimpse of my reflection in the halls and I completely broke down in tears. It made me even more depressed. By the time I got home, I was depleted emotionally. And then I remembered that sometimes my sarcoidosis flared with stress. Then I suddenly stressed out about how not to stress myself out and cause a flare. It was like being on a hamster wheel and not being able to get off. It's the things like that that affect the patient's happiness and joy. Those things really matter. Being able to have dinner with your children and not be fatigued, being able to climb a flight of stairs without feeling as though you need a defibrillator, being able to feel confident in who you are, even though you have sarcoidosis. You may even present it on your skin. Everyday living and quality of life is imperative to patients. Patients need pharmaceutical companies to consider all symptoms, engage in multiple scenarios of how treatment will look for patients of all economic backgrounds, and create a partnership with the patient community to refine their mission and approach to creating viable solutions.
Thank you, Erica. That's just incredible. So important and such an important message. Outcomes that matter to patients, and that's how we can gather those. Thank you. Next question for you, Tricia. What are some of the things that FSR supported Dr. Shukla and the aTyr team for the phase 1-2 study in pulmonary sarcoidosis?
Thank you so much, Shazi, and thank you for having us being part of this discussion. FSR is so thankful to aTyr for reaching out early in the clinical trial process to ensure that the patient voice was at the center of the trial. The Foundation for Sarcoidosis Research, or FSR as we're known, is the leading international nonprofit organization dedicated to finding a cure to sarcoidosis and improving the lives of patients through research, support, and education. We have a strong relationship with the world-leading experts. We have a finger on the pulse of sarcoidosis research, and we're able to provide meaningful reflections from our engagement with patients on their desired needs, their hopes, and their concerns about clinical trials. aTyr recognized our position in the community and sought to find meaningful ways for us to play a pivotal role in building their relationship with the KOLs and with the subject matter experts, and for identifying patient needs to help shape the trial. What is unique and different here was the invitation for FSR to have a seat at the table and a voice at every stage of the trial. Not just to reflect after a protocol is written or after all the outcomes were selected and vetted. Listening to the patients means being willing to adapt and adjust. And this is truly where aTyr excelled. This played a significant role in the trial's success. As you heard from Dr. Shukla and Erica with regards to steroids and paying attention to what is most important to the patients. aTyr wasn't afraid to ask the hard questions and expected the unexpected answers. Advocacy organizations must also do work here to provide assistance. My recommendation to advocacy organizations is to start now by building strong relationships with your clinicians, to educate your community. Reach out to industry and welcome them to your table and ask them to welcome you to their table. Survey your patient community. As you learn more, ask your community to reflect and provide feedback. The partnership that we have with aTyr created true buy-in and trust in the community, which is central to all successful clinical trials. And it made it possible for us to work together to finish recruitment during one of the biggest research disruptors of our time, the emergence and surge of COVID. Collaboration is key, and progress is only possible together.
That's great, Tricia. And I know FSR is just a remarkable example of such a great collaboration in industry. It's not just with ATIRE. I know you're working with other organizations, other members of industry. So this is a great example to share with others. Thank you. Dr. Shukla, what did you do to particularly adapt to the challenges with COVID-19 and challenges with enrollment, to continue enrollment especially?
That was a huge challenge here. And I think it wouldn't have actually, we wouldn't have been able to move through this trial, which could have been a broken trial. Many sponsors, biotech sponsors, pharma sponsors had to deal with these challenges. And sometimes trials were broken. And that's really where in the middle of a trial, you just can't continue enrollment, and you end up with just a limited data set to look at. And then very difficult to then make judgments around trends of efficacy. I think what I want to go back to what Tricia said. I mean, the buy-in early with patients, that only comes if you have trust. And I think we were able to get that early trust from the organization. I can remember initially trying to maybe think about moving into sarcoidosis, even with some key opinion leaders. And I'm not a pulmonologist, but getting maybe 1 minute of their time while they left a medical conference and said, I'm going down the escalator, just talk to me now. They don't. So it was one of these things to say, hey, look, I think I have a concept here that could be interesting. But the FSR brought some of those experts to the table, and they have the respect of the patients. So sometimes it was uncomfortable to be able to, show and tell. And the trust starts with also being able to understand that you may not hear things that may fit exactly what you want to do operationally. It may require an endpoint that maybe you don't necessarily think, hey, is that something we should research? We incorporated some ideas, not all. I think that give and take is part of why this was an effective relationship. And once that foundation was built, that allowed us during COVID, I think, to frankly have the ability to, marshal through a really difficult time to enroll patients. It helped, I'll be honest, that certain patients, as a blinded study, felt better. They started to perform better from a data point of view. But what mattered to them was getting off steroids and feeling better. And that kept patients motivated in our trial. Again, if I was following a biomarker, a lung biomarker, maybe if that was a primary endpoint, we wouldn't have been as successful. But I do know patients, put it on the line, maybe they didn't know what they were on, whether placebo or drug. I can think of one patient that flew, hundreds of miles for their monthly visit, to continue in the trial, and not knowing what they were on, but they were contributing to the data set. Some of that, I think, had to do with some of the early good foundation we built in building that trust with, a veritable organization like the FSR. They knew us, so they were able to also say, this is a credible group. And then patients stepped up. They basically, at the end of the day, without knowing what they were on, said, this is an important data set that we are creating beyond just what the outcomes here are, because I think there was that trust. So we're really, really fortunate that the patients, continue to come in. Some centers had to shut down more than others. We did have to make some amendments and some slight tweaks to our protocol because some things we just were unable to access during COVID. But at the end of the day, the patient's involvement in the trial allowed us to look at this data set. And at the end of the day, it's turned out well for us. But, part of the journey here is also creating data. That doesn't occur unless, patients really, get involved. And the only reason they got involved is, I think, because we have that foundation.
That's great. Then Tricia, a question for you with the pulmonary sarcoidosis trial. What were the learnings from there? Burdens for patient participation, any specific learnings that you can share?
Sure. Yeah, I want to build a little bit on what Dr. Shukla was just talking about with regard to COVID and that trust that was built, because I do believe that that ended up shaping quite a bit of what we were able to do during those challenging times. So during that time, FSR and ATIRE worked even more closely to keep an eye on the shifting landscape, to be able to pivot in those terms and be able to have constant conversations. You know, we worked really closely with the trial sites. We spoke frequently with the trial coordinators. We kept ATIRE informed and they kept us informed. Again, the relationship that we built early on just continued to grow throughout what is the most challenging thing that you can have, the risk of trials being completely shut down. We had frequent conversations with the sites to understand what challenges they were facing, and we built really strong relationships with coordinators who are the front line in a lot of ways of these trials. And it was really important for us to have those open conversations to hear what they were facing. We created a network that allowed them to share with each other and provide some best practice tips for each other, which made it possible for them to have really meaningful conversations about why they should continue to travel to the trial and engage. We encourage patients to stay in communications with their doctors and the trial sites and to let them know any challenges in particular that they were facing so that some solutions could be proposed or thought of in the moment. We were careful to keep the whole community up to date on the trial every step of the way. And again, we were really thankful to ATIRE for helping us do that, being very communicative with the community in order to move that forward. And you know, this was particularly critical, I think, when we think about COVID, because the noise of COVID has really dominated all discussions right now over the last 2 years. And so finding a way to make sure that we were able to break through the importance of participating in this clinical trial, being active in clinical trials, and hearing directly, repeatedly from the organization, and ATIRE has been very active in that, to make sure that people knew that this trial mattered. Regardless of what the outcome was. And again, we had a positive outcome and we're thrilled about that. But regardless of the outcome, it's important that the trial stayed front and center. The pandemic created an urgency around considering ways that we might want to think about for future decentralization of clinical trials. Travel became more complicated. Patients at risk of contracting COVID, especially when we start thinking about the sarcoidosis community, this was a serious factor for whether or not they would participate. Patients, in fact, were questioning things like whether to go to the doctor at all. That's one more place they had to go out into the community, and they didn't want to run that risk. And of course, that became a complicating factor for clinical trials. Furthermore, the pandemic made the need to consider specific challenges for the underserved communities even more salient. For years, underserved populations have had limited access to clinical trials because of transportation issues, because of concerns with taking times off, or other financial and personal concerns. And the pandemic has just highlighted what is basically an outdated process right now in our current clinical trial model.
Thanks, Tricia. Yeah, and then with you mentioned decentralized trials. Do you see that possibly some learnings from what you worked on for improving ways that rare disease trials are conducted, just overall?
Yes, I mean, I think that it really does put a spotlight on the need right now. COVID has put a spotlight on the need right now for focusing on what I think is a gaping hole in our healthcare system in trying to address the needs for decentralized clinical trials that can help with broader diversification of trials and making sure that we have representation of all voices in those trials.
Great, and that leads to my next question for Erica. Erica, why is it important to have good representation in clinical trials? What are some of the considerations that you think are important for industry to consider to improve diversity in clinical trials?
I think it's important to have good representation in clinical trials because not all communities process or navigate the disease the same way. For some communities, the stakes are much higher and the consequences are much dire. For example, Black American women are 3 times more likely to develop sarcoidosis than white women and white men. Black American women have more severe and chronic forms of sarcoidosis and higher rates of hospitalization and mortality. Therefore, it would be a value add to the clinical trials to have each community properly represented, especially those communities that suffer greater health outcomes. What we want to do is actually get patients, to the kind of bridge or gateway and meet the pharmaceutical companies where they will understand that to have each community properly represented, especially those like Black women who suffer more barriers to treatment, they will have a better clinical trial. Only 20% of health outcomes are determined by the services you receive from your PCP and within the confines of a hospital. 80% of your health outcomes are determined by demographics. Black women navigate racial barriers stemming from implicit and explicit biases rooted in stereotypes and misinformation, as well as systemic factors such as the location of the clinic, types of insurance taken, who works at the clinic. Then there are also gender-related barriers stemming from inequities. Lastly, there are socioeconomic burdens because Black women are, we're still significantly undervalued and make noticeably less than other ethnic groups. Lower socioeconomic status due to income, employment, or education can result in decreased access to care or care specialists. Lack of access to medications, lack of insurance, and severe challenges with being consistent with your appointments due to transportation and poor provider-patient communication. Those in research and pharmaceutical spaces need to consider having diverse clinical trials as a gateway to learn more about varied accessibility, affordability, and the possible monetary burden associated with long-term use of the drug solution for every ethnic community. For example, if a working Black American mother has aggressively active sarcoidosis, how can you make the trial accessible to her without transportation burden? How can the drug be developed so it's not cost prohibitive? And will the drug challenges be easily surmounted with everyday living? What's the lead time for the drug to kick in order for the quality of life improvements to be felt? All of these scenarios and permutations are outcomes that should be explored in the trial. And that's why, again, I sound like a broken record. It's imperative to have all communities represented. More importantly, it's critical to have the community most adversely affected represented in the trial. My thought process, heartfelt, is if you treat the most vulnerable of those suffering from the disease, it benefits all the patients with the disease.
That's so great, Erica. And that really hones in on the message, the key message to any pharmaceutical companies or biotech tuning in today that are looking to run clinical trials in the rare disease space. It's really such an important message on these considerations that Erica has reviewed. Thank you, Erica. So before we end our session, I'd like each of the panel members to really touch on what are the lessons learned that industry and advocacy organizations should be aware of to ensure successful clinical trial recruitment. We can start with Dr. Shukla.
Well, I think clearly if you're getting involved early, it can be scary to do that. You may get feedback you might not like. You may not fit some sort of development plan that you've already worked out, but getting involved early is really important. Also understanding that when you're in rare disease, Tricia, you said this, the coordinators, I think would really help here with the FSR, having a clinical trial network, a consortium of people that were really dedicated at the trial site. That was huge. And I think that's something I want to really highlight here. And the last component here is speaking for the industry side, understand that, when you're working in rare disease, hope is a real powerful tool, but also something that comes with a lot of, you have to be very careful about it, which means really being transparent about what your drug is, potentially doing, having that dialogue with patients, providers, advocacy groups like the FSR, really understanding, working with them, because I think it's very important for us to not trade on that hope. We have a responsibility to say, okay, we're going to do this carefully and really test things rigorously in a manner that is most important, frankly, for the patients, which is, I think, was our approach. And, we probably still get some criticism about it, but that's okay, because I think our outcome wouldn't be as dramatic, I think, unless we took this collaborative approach. It wouldn't have occurred that way. And I hope it's a model for other organizations who really think about working with groups like the FSR, really early on, understand the responsibility they have. And also it helps if there's also a really, really tight network.
That's great. Thank you. Tricia?
Yes, thank you so much. And I just want to echo, I think, what Dr. Shukla just said with regard to hope. Hope is vitally important, and it does need to be treated, with kid gloves and be very careful, because it is a central piece to what helps patients get through every day as they're living with these severe chronic illnesses. And so, one of the things I think for patient advocacy organizations, as you're looking at this, is to help people understand that clinical trials are hope. And even whether or not a clinical trial is successful, the hope is in the learnings. And the hope isn't always in the outcome. And that's a big part of the education and the role that we play in the advocacy organization, to help understand that we can build on the learnings, regardless of whether a trial is successful or not. We can build on those learnings and move towards a better future. We were successful here. Again, aTyr did a wonderful job and did have a successful trial. But whether this trial was successful or not, there were learnings that they would have been able to build on into the future. And that's really where the hope lies. So I thank you, Dr. Shukla, for bringing that up, because it is really important, I think, to make sure that we treat that hope really carefully. If I could only provide one takeaway to the industry and one takeaway to advocacy, I guess I would say to industry, it's important, as Dr. Shukla said, to make sure that we bring in the advocacy organizations early, and that the communication with the advocacy organizations is every step of the way, not just a quick early check with them and see where you are, and then later on a check, but keeping the advocacy organizations deeply involved and having that constant communication. And for the advocacy organizations, I would say, raise your hand, raise your voice, and be heard. It's really important that you explain and let the pharmaceutical companies know that you're here, that you're supporting their efforts to support your community, and that you want them to be able to hear what the patients need to say. It's essential for industry and advocacy organizations to have this true partnership in the process. As we were talking about before, and I think this is really the take home from my perspective, if you want to build trust, it has to be done together.
Absolutely. Thank you, Tricia. Erica, how about you?
That's my big takeaway, would be that patients' empirical experience is, it's invaluable into helping researchers and pharmaceutical companies create viable, life-changing solutions for rare diseases. It's critical to be intentional, bringing patients in of diverse backgrounds to the table. As a Black American woman living with sarcoidosis, I would consider a clinical trial that was accessible in multiple locations, that had consistent check-ins for patients to discuss not only their reaction to the drug, but their mental health status whilst going through the trial and the process. I'd be ready to engage in a trial that saw me as a stakeholder and readily acknowledge the disparities in care and treatment for my racial and ethnic community. And I'd want to participate in a clinical trial where I was more than a data point, but I was seen as a true partner in a process that sought to improve the quality of life of those living with sarcoidosis. Therefore, I think it's imperative that all communities are represented and all disparities considered.
Wow, great. Thank you, Erica. Thank you, Dr. Shukla, Tricia, and Erica, and all who have joined today. We've certainly had challenging times with the pandemic, lots of great lessons here today, and advice for clinical trial recruitment successes in the future. We have to remember, it's so important to understand all of the stakeholders, patients, the patient advocates, the entire community, which also includes the caregivers and care partners. They're all such important stakeholders in the rare disease space for successful drug development. Please feel free to reach out to us directly with any questions you may have. And thank you again for joining our session.